Thank you very much for inviting me to talk about this very important topic of clinical management in people aging with HIV. So here are my disclosures. So in this talk, we will first start with some very basic concepts of aging and the current evidence of a more rapid aging process among people living with HIV. Then we will discuss how aging is manifested clinically and what we can do to prevent the complications of aging for our clients. Lastly, we will briefly look into the different models of care in taking care of older adults with HIV infection. So, what we're most concerned about aging is in fact biological aging process, which is in fact the failure to maintain homeostasis and the repair functions at cellular and molecular levels. And this is manifested by abnormalities in different organ systems. So a lot of work has been done to look into the aging process in people with HIV infection. And the diagram here on the left more or less summarizes our current knowledge regarding this aspect. So the blue line here represents the normal biological aging process among the general population. And once a person is infected with HIV infection, biological aging becomes accelerated. With the initiation of antiretroviral therapy, this aging process slows down. However, even with viral suppression, people with HIV do behave more older than the general population. And this is manifested by domains such as accelerated immunosenescence, mitochondrial dysfunction, and epigenetic alterations. And here are some of the examples of some studies looking into the aging process among people with HIV infection. So using epigenetic clock, for example, in the study on the left here, people with HIV are older than HIV-negative controls. However, the age gap is closer after the initiation of antiretroviral therapy. Another study on the right here looks at the brain age by measuring white matter changes using some sophisticated imaging techniques. And again, you can see that there is a wider age gap between people with HIV infection and compared to the general population. But the gap is closer for those who have been started on treatment. And the attenuation of the biological aging process by antiretroviral therapy is probably because of ongoing inflammation and also immune activation despite viral suppression. Telomere length is another commonly used marker to measure biological aging. And in this study, in people with HIV infection or at risk of HIV infection, it nicely showed that telomere length was associated with various diseases process, for example, inflammation, endothelial dysfunction, as well as cardiovascular disease and cognitive function. Therefore, not surprisingly, the accelerated aging process in people with HIV do have a variety of clinical manifestations. So firstly, it has been shown in multiple cohorts that people with HIV do have an earlier onset of age-related comorbidities than the general population, usually by around 5 to 10 years. And these diseases included things like cardiovascular diseases, chronic kidney diseases, diabetes, osteoporosis, etc. Secondly, people with HIV infection are prone to have more than one comorbidities, resulting in the problem of multimorbidity, usually defined as the presence of 2 or more comorbidities other than HIV infection. And interestingly, studies have shown that these comorbidities carry distinct patterns of clustering, meaning that if a person has one comorbidity within a cluster, they are more prone to develop other comorbidities within that same cluster. Multimorbidity is also an example of a long list of geriatric syndromes. These are syndromes comprising of a constellation of symptoms that are commonly seen in older people. And most often, the cause is multifactorial. And instead of representing a single disease, These syndromes usually involve multiple organ systems. And examples of geriatric syndromes include polypharmacy, cognitive impairment, urinary incontinence, frailty, sarcopenia, and falls. Polypharmacy is a condition closely associated with multimorbidity. In most studies involving people with HIV, it's usually defined by the use of more than 5 co-medications other than the antiretroviral drugs, and is more common among people with HIV than those who are HIV negative. Polypharmacy, of course, can cause a lot of problems, including drug interactions. Although older people are usually more adherent to antiretroviral therapy, it is quite well known that older people can be less adherent to the non-antiretroviral therapy co-medications. And other than experiencing physical symptoms because of the side effects of these co-medications, polypharmacy, in fact, can increase the psychological burden for older people in adhering to complex regimens. The issue of falls is another commonly seen geriatric syndrome among people with HIV. For example, this study from the US, you can see that the prevalence of falls and associated fractures can be very high among older adults with HIV infection. And this is not very surprising because the associated risk factors, for example, polypharmacy, alcohol use, substance use, etc., could be more prevalent in people with HIV infection. Frailty is another geriatric syndrome that is gaining more and more widespread attention among people with HIV infection. Frailty is the decline in physical and functional reserve, increasing a person's vulnerability to adverse health outcomes at times when they experience some stresses. And again, in most studies, the prevalence of frailty is more common in people with HIV than the general population. And importantly, frailty increases the risk of a wide spectrum of adverse health outcomes. There are different tools we can use in the clinic to measure frailty. Frailty phenotype is the most classical definition of frailty. However, there are also some other simpler tools which can serve as screening tests in the clinic. So if we look at the traditional classification or definition of frailty using the phenotype, we are looking at 5 different parameters, including unintentional weight loss, exhaustion, a low level of physical activity, a slow normal gait speed, and a weak grip strength. So if there is a presence of 3 or more abnormal parameters among these 5 items, then the person is having frailty. And if there is the presence of abnormalities in 1 or 2 of these components, then that person has pre-frailty. Another closely related concept of sarcopenia is also gaining more attention among people with HIV infection. Sarcopenia is defined as the presence of a low appendicular skeletal muscle mass, together with low muscle strength or low physical performance. In clinical practice, appendicular muscle mass is usually measured by either DEXA scan or by electrical impedance analysis. Muscle strength and physical performance can be measured by the different domains as shown here. And the cutoffs shown in this slide are taken from the Asian Working Group for Sarcopenia. In our center, we have looked at the problem of sarcopenia among 150 older people with HIV infection with a mean age of 60 years. And you can see that a very high prevalence of sarcopenia was identified from our cohort. And importantly, the presence of sarcopenia and severe sarcopenia are associated with adverse health outcomes, including an impairment in instrumental activities of daily living. Therefore, with the more accelerated pace of aging in people with HIV infection, it is very important that we should be aware of the interventions that are available so that our clients can age well. Early initiation of antiretroviral therapy is definitely the key component in the management of older people with HIV infection. In most countries around the world, initiation of therapy after the diagnosis of HIV infection is not a problem. It's standard of care in most parts of the world. What is more challenging in older people is that they often experience a delayed diagnosis and late presentation with complications. As mentioned, people with HIV infection can present with comorbidities at an earlier age than the general population. Therefore, doing preventive work and also screening for these comorbidities would be very important and really should start early in their life. And there are different measures to prevent and also to identify these comorbidities, including co-infections, and also some age-related chronic diseases as shown here, and of course, cancer screening. It is now more commonly seen that in several HIV clinics around the world, people are getting more aware of the problem of geriatric syndromes and conditions among people aging with HIV infection. Therefore, it would be important to conduct comprehensive geriatric assessment to look at various domains, for example, their physical function, their mental health, so items like screening for depression, mood disorders, and stress, etc., assessing their cognitive function, performing tests to assess frailty, to measure their functional status, and of course, very importantly, their quality of life. Preventing and minimizing the issue of polypharmacy is also very important. Prescribers should be aware that unnecessary and inappropriate medication use should be minimized and really avoided. And of course, there are different approaches that can be done. For example, education of prescribers and also getting help from pharmacists, and also relying on more advanced technological tools can also help to achieve the optimization or minimizing polypharmacy. Lifestyle modification is also very important in our discussion and our routine care for people with HIV infection. So for issues, for example, frailty and sarcopenia, exercise would be very important. And it has been shown that combining resistance, aerobic, and balance exercises, for example, can prevent or improve frailty and sarcopenia and prevent the problem of falls. In terms of nutrition, this is very often a neglected issue in people aging with HIV infection. And with ensuring adequate protein and caloric supplementation would also increase their physical performance and prevent issues of frailty and sarcopenia. The recently published PLWHIV trial also brings good news to our patients. Of course, we know that people with HIV do have a higher risk of comorbidities, including cardiovascular diseases. However, the results of the PLWHIV trial shows that with appropriate intervention in people even with low to moderate cardiovascular disease risk, the addition of a statin can actually reduce their major adverse cardiovascular events. Therefore, the intervention using these preventive measures should really be included in our routine care and discussion with our patients. And lastly, the optimal mode of delivery of care for older adults might vary in different settings, but we should take into the considerations of the challenges faced by different stakeholders. People with HIV, as they get older, do face complex medical and psychosocial issues, and it should be remembered that a person-centered care is very important to improve or maintain their quality of life. And people who are taking care of people with HIV are usually from infectious diseases field with very minimal experience in treating geriatric conditions, for example, frailty. And very often a multidisciplinary team is required to provide optimal care for people who are older and with multiple issues. On the other hand, referring care to geriatricians might not be the optimal approach because geriatricians are not familiar with HIV infection and the associated treatment, and aging-related issues occur in relatively young people with HIV might differ from the usual issues faced by geriatricians. So whatever approach is adopted, it is very important that a person-centered care is delivered so that each person with HIV infection can develop an individualized goal with the aim to maintain their functional capacity as much and as long as possible. And also, if possible, a multidimensional interdisciplinary health service should be considered in optimizing the care to cater for both the physical and psychosocial needs. So in the interest of time, I'll stop here, but I will be most happy to continue the discussion in the Q&A session. So thank you very much.